Hi everybody. Today we will be starting with another session on ultrasound examination of urinary bladder. My name is Dr. Vibhu. I will be presenting it to you. So this is how the technique for scanning of for ultrasound of urinary bladder. Bladder is mainly located in the pelvic area, so you have to have a full bladder. This is a prerequisite for a bladder study. At least 200 cc of urine should be there for adequate distension of the bladder, and always try to see in the longitudinal plane first. So this is how the longitudinal appearance of the bladder will see. It's in the long axis. You can see the walls of the bladder, the inner mucosa, and intraluminal urine you can always check. So then moving on, you should change the longitudinal plane towards the transverse plane at this site only, and this is how the transverse appearance of the bladder will come. You can see a square shaped structure, well distended, with peripheral walls, and you can very well see all the contours of the bladder. Because of the fluid within the bladder lumen, a good acoustic window is achieved, and any pathology can be easily localized within the bladder lumen. So the protocol for ultrasound imaging of a bladder is the ultrasound is an important tool for assessing bladder wall thickening, trabeculation, masses, diverticula, and always check for pre and post micturition volumes. View junctions can be very well visualized. Any bladder calculi or any foreign bodies should be looked for, and use the full bladder as an acoustic window to assess the prostate also and the gynecological structure in females. So these are the common pathologies that you can look for. First thing is trabeculations, then diverticulum, calculus, uretroceles, urinary bladder infection, and then adenocarcinoma, transitional cell carcinomas. So scanning technique will show us examine the bladder sagittally in midline. Now then you should angle it laterally and sweep the probe both left and right, and check for the lateral margins. You should rotate it 90 degrees to achieve the transverse plane, and then you can project it as close to the perpendicular of the bladder wall as possible. So you should look for ureteric jets. Then that will confirm the renal function, ureteric patency. And you should put color Doppler to see the ureteric jets. That will make it more clear, and document the normal anatomy and any pathology that is found. As a rule of thumb, the bladder should empty approximately 10% of the pre-maturation volume. If the initial post-void volume is greater than 100 ml, then you should ask the patient to go for a post-void scan. So this is how the trabeculated bladder will look like. You can see these rugged pattern along the wall. It's a non-compliant hypertonic bladder which results from hypertrophy of the muscle coat, usually caused by obstruction of the urethra, and increasing post-void residue. In such cases, the post-void urine is increased significantly because there is loss of bladder function in such patients. So then after these trabeculations comes the diverticula. Diverticula are these outpouchings from the bladder wall, where the mucosa herniates through the bladder wall, and they may solitary or multiple. Considering the size, you can see there's outpouching, and you can see there's a flow within these walls. So the urine is going through and depositing here, and these are like sources of infections in patients with UTI, recurrent UTI. So this is without Doppler. You can see there's outpouching which is showing communication with the bladder wall. So another case for bladder diverticulum, very well diagnosed on ultrasounds. So they can be bladder calculi. Calculi are like renal calculi. Similarly, they can migrate into the urinary bladder. Can be divided into primary and the secondary stones. Primary are when they are formed within the urinary bladder. Secondary stones are either from the renal calculi, which have migrated, or they can be from the concretions or the foreign material. Like sometimes patients with recurrent catheterization can have bladder calculi. So ultrasounds can easily show these mobile echogenic shadows which are within the bladder wall, and they also associated with wall thickening and due to inflammation. So you can see here these are the large calculi within the bladder lumen. And they're also having shadowing behind, but they can be very well visualized on ultrasounds. Ureteroceles are congenital dilatation of the distalmost portion of the ureter. So the ureter tries to herniate into the bladder and through the VU junction, and there are two main types of ureterocele which both result from cystic ectasia of subepithelial portion of ureter as it enters the bladder. Simple or ectopic, the ureterocele that occurs at a VUJ is simple, whereas which occurs at another site is ectopic. So most commonly we see a simple type of ureterocele. Here you can see the bladder and you can see the ureter are herniating into the bladder lumen. So this gives a cobra head appearance, and we call it as ureterocele. And you can also see sometimes the stones get lodged within this, and because of the stones they become more prominent. Okay, cystitis is another condition when there is bacterial overgrowth within the bladder lumen, and causes bladder wall thickening. Bladder infections are one of the most common bacterial infections to affect humans, with up to 1/3 of all females at least one infection at some point in their lives, and they suffer from these UTIs or cystitis. Ultrasound will show inflammation of bladder wall, infection, radiation, drugs, and trauma. The bladder appears sonographically normal in most cases, but there can be edema. Bladder mucosa is normally less than 2 mm thick at full distension, but in such cases it will be more than 2 mm. Yep. So here you can see a thick wall gallbladder and in full distension. Thick wall bladder and full distension, and this is a classical case of cystitis. Sometimes these they can be predisposed to adenomatous hyperplasia or these projections, polyps within the urinary bladder. So they can be malignant and they need to be biopsied. So these are all predisposing factors for malignant growths, and one can be able to distinguish benign urinary bladder tumors. So multiple in the history of imaging, we can find that there are many tumors which are localized within the urinary tract or urinary bladder. So these are benign ones are like leiomyoma, hemangioma, neurofibroma, schwannoma, and clinically they all have morphological characteristic and immunohistochemical features are very well visualized during the cystoscopic biopsies which we do. And the review also described the pathogenesis of inflammatory myofibroblastic tumor details. So these benign lesions should be well distinguished and localized within the. So like this is a case of leiomyoma of the urinary bladder. It is a rare tumor, but it can it can be found in the population, and the most common presenting complaints are urinary voiding symptoms such as obstruction and irritation. Ultrasound examination typically shows a smooth walled, hypoechoic, homogeneous solid mass in the bladder with thick echogenic surface. Other than, again, every time we see some mass within the bladder lumen, we should localize it. So we can't put a proper histopath diagnosis to it, but we should localize it. We should mention that how much area is it going outside the bladder wall, or is it causing any infiltration to the adjacent tissue? Is it vascular? So all these findings, the size of the lesion, it matters. So this is the case of inverted papilloma, and you can see the mass within the bladder lumen. This is big schwannoma within the urinary bladder. It is again a rare tumor, and most commonly it is with the nerve sheaths, but it can be present in bladder. So bladder cancer is several types of cancers are there because of the urothelium. epithelial lining of the bladder. There can be hyperplasia, and it can lead to benign cancers or malignant cancers. Lymphomas, sarcomas can be there. Most common type of bladder cancer is the TCC, the transitional cell carcinoma, and the squamous cell has the worst prognosis. It is the least common and has the worst prognosis, associated with chronic infection irritation, and in underdeveloped nations, it can be associated with schistosomiasis or schistosoma hematicum infection. Adenocarcinoma called for 1% of the, and most common in bladder extrophy. This poorly responds to the radiation therapy. So there again an image of the bladder. You can see there is debris within the bladder, lumen and a mass localized in the upper wall of urinary bladder. It is seen projecting within the bladder lumen, and there is infiltration. You can't demarcate the wall of urinary bladder. So this was a case of TCC. Again, you can see this is vascular mass within the bladder lumen, causing obstruction at the VUJ level with the subsequent right-sided hydroureteronephrosis. Again, this is a carcinoma. You can see mass, big mass within the bladder lumen, showing vascularity. There can be more than one masses, there can be multiple masses, and always go for a post-void residue, pre-void and post-void. Then you can know that whether it is causing any obstruction or not. Okay. Thank you for the time. This is it for imaging of urinary bladder.